All right, everyone. Professor DeGrazia here. Today we're going to start segment 2 of 3 of our Electrolyte Imbalances module. Last segment we covered the basic functions of electrolytes, common causes of imbalances, and also patient considerations. But today we'll focus more on assessment findings and some complications. So content overview. In this segment, our objective will be to be able to recognize assessment findings and complications if these electrolyte imbalances go untreated. These will include subjective and objective assessments, as well as EKG changes and lab results. And then also some complications we'll explore as well. So as we continue to review these lab results, I wouldn't stress too much about the specific numbers. You should have a general idea of the normal for each sodium, potassium, calcium, and magnesium, the 4 that we're focusing on this module. But you should know, the high and the low values. But Epic or the lab charting system will always flag an abnormal result for you. But basically you should be able to tell if a patient comes in to triage and they're saying that they have an abnormal lab result and they tell you have a potassium of 7, you should recognize that that's a lot more severe than like a sodium abnormal lab of like 146, 147. These labs were taken, or these values were taken from Cleveland Clinic in 2021, but most resources you guys see will have similar numbers to this. Does anyone have any questions, concerns about any of these lab values? Okay, let's keep moving. So subjective findings. What you'll realize is that a lot of these are non-specific until more of their severe stages are reached. Think about a lot of fatigue and weakness for most of these. Hyponatremia is a severe issue that basically gets a guaranteed ICU admission because we have to replenish that sodium really, really slowly, which we'll talk about in the next module where we talk about treatment. So with this, expect to see more lethargies, delirium, changes in consciousness, ataxia. That's more of your severe stages of hyponatremia. And then hyperkalemia, it's mostly asymptomatic until severe. That's where we go into our cardiac issues, which we'll talk about shortly. And then also with hyperkalemia, you'll have more of those musculoskeletal issues, so muscle cramps, tingling, paresthesias, fatigue, and confusion as well. So similar things with calcium and magnesium, hypercalcemia, very non-specific, fatigue, weakness, anxiety, increased sleepiness. And then hypocalcemia, once again, ranges from mild to severe. Severe, you're going to have those neurologic issues, tetany and paresthesias. And then magnesium, same for hypermagnesium as hypocalcemia, where you get those severe lack of deep tendon reflexes, impaired consciousness, disturbed gait. And then moving to hypomagnesemia is it's more of a chronic issue, so some drowsiness and fatigue. So 2 specific objective findings that I want to focus on are hypocalcemia, and these should be familiar to you as well. Chopsticks is displayed on the right over here. That's kind of when the patient's face gets tapped, their cheek kind of twitches. And trousseau's is on the left over here. That's when if you squeeze a blood pressure cuff for an extended amount of time, you'll kind of get this carpal spasm. This occurs because the neurons are so unstable from the lack of calcium, so they're more likely to fire spontaneously and produce that kind of tetany. This video on the right, which it should let me show, is actually a real-life patient. So first we have the chopsticks here. You can see how his face is a little bit twitchy. And then in the second video, this is them inflating the blood pressure cup, keeping it on for a decent amount of time, only like 2 or 3 minutes. You'll slowly start to see here, it's not letting me circle it, see his hand kind of cramping in a little bit, kind of near. Now you can see it a bit more. And this is a real-life patient with hypocalcemia. So it just shows, those are 2 of the most significant objective findings, which you'll probably remember from nursing school. All right, so EKG changes. I know you all had to take a EKG / telemetry test as part of this nursing orientation program, but let's just review a little bit more. So we have different phases: depolarization, repolarization, and then you'll probably remember the terms resting potential phase and then absolute refractory period. That's when a second QRS complex cannot be initiated. So our QRS is formed by these electrolytes moving in and out of the cells, so which is why when electrolytes are imbalanced, we see EKG changes. So phase 0, we have the rapid depolarization, sodium rapidly moving in and calcium moving slowly in. Phase 1 is so short and it's basically hidden by ventricular depolarization because the atrias are much smaller in comparison to the ventricles. And then we have our plateau phase in phase 2 where potassium's rapidly moving out and calcium slowly moving in. And then phase 3 and phase 4 as well. So moving on to the EKG changes, starting with potassium, hyperkalemia is pretty much the most significant EKG change as potassium sends the electrical activity through the heart for depolarization. If there is one phase I want you to remember out of all EKG changes associated with electrolyte imbalances is that hyperkalemia, you're going to have tall peaked T waves. That should automatically spike in your mind. Whenever you see that, you're thinking hyperkalemia. And this is during ventricular repolarization. And also just to remember that the EKG changes that's seen with hyperkalemia also resemble hypermagnesemia. We also have this push and pull idea where in hyperkalemia the T wave is pulled upwards, creating that tall tented, and stretches the remainder of the EKG wave to cause that P wave flattening. We also have PR prolongation and QRS widening. And pretty severe with this, it can lead to heart block, VFib, and even cardiac arrest. So this one, definitely, like I said, if the patient comes in triage, you're going to be concerned if you hear a high level of potassium. Moving on to hypokalemia and then also hypomagnesemia. Once again, those two are connected. These also increase the risk of critical ventricular arrhythmias. So can anyone tell me what this rhythm right here on the right is under hypomagnesemia? Anyone? Okay, so if you said VTAC, you're actually really close, but it's actually a specific type, and this is known as Torsades de Pointes or polymorphic ventricular tachycardia. This is associated with hypokalemia and hypomagnesemia as they lead to acquired long QTS or QT syndrome. So basically spacing out that QT, leading to that polymorphic ventricular tachycardia. Does anyone know what we give to treat torsades? That's right, magnesium, yes. So we give magnesium, which makes sense because its risk is increased by having low magnesium levels. So going back to that push and pull theory, hypokalemia creates the illusion that the T wave is being pushed down with the resultant T wave flattening or even inversion, ST depression, and then also prominent U waves, which you can see right over here in this corner. Moving on to sodium and calcium. Sodium, I really can't find anything too specific for EKG changes related to it. Nothing that's significantly going to point out that this is directly related to sodium changes. If there is, it's probably related to something else, so we're going to explore other causes. Calcium, we see issues with the QT interval, so this shortens in hypercalcemia. Remember, very excited, so they just kind of want to go because they're very excited. I also want to show you another video that you don't have to watch. We're not going to watch this now, but it's just another helpful video for you guys to watch later on where you can get a more in-depth explanation of the EKG changes from electrolyte abnormalities. So once again, I'll send you all these PowerPoint after this class. Go back, review, watch these videos again. Just take your time with it. It should be review, but some of this might be new. So we won't watch that now. I'll move ahead. So complications, I kind of summed them all up here. Cardiac, these are going to be our biggest concerns, right? We have cardiac arrest or asystole, ventricular arrhythmias, VFib or VTAC, and some heart block. And what is this most severe with? What are we going to reach out for or look out for with this? Hyperkalemia, yes, potassium. And what main EKG change will we see with elevated potassium? Perfect, tall peaked T waves. Keep remembering that. We also look out for this with hypokalemia, hypomagnesemia, and calcium imbalances are going to cause those really cardiac focused issues. Neurological and musculoskeletal concerns are also strong with the more severe cases. So you're going to see maybe even seizures, brain herniation, that's common with sodium imbalances, paralysis even, and then that weakness and muscle cramps as well. For GI complications, constipation or diarrhea, for the electrolytes we covered, it's mixed motility, either promoting or slowing digestion. And then also something to nausea and vomiting. And in our next segment, we'll talk about how we are going to prevent these complications. So today, just to recap kind of again, we used engaging videos and real-world examples to kind of break up the lecture content and keep the material engaging. I supplied real-world examples to input experiences that students could understand, such as the triage example. And our EKG images help to explain content, which may benefit some students who may prefer visual learning. I asked questions throughout the lecture to prompt student on short-term information recall and just keep them actively listening. And then I also supplied some additional resources to review the content after class. Most of this should be review, but sometimes this is new, so we just allowed space and time for that content to be really learned. The videos all have the ability to have subtitles as well if students need to listen again on their own. And the slides use pretty simple text and display, so nothing was too confusing or distracting for them. We do have some time now for additional questions at the end. Does anyone have any questions? Okay. Here are additional references that I have, things that we used today to create this slide, and then other things if you guys want to go home, explore any more. Besides the materials that I already gave you, these are all great ones to utilize. Thank you all. I'll see you in segment 3. Thanks.